Again, welcome back to our Implementation Science reading course, and this is our last session. Thank you for being flexible on the date and the, the scheduling challenges, but we're excited to see so many of you here. Historically, in previous years of this reading course, we kind of ran the content topics all the way to the end. So I think session 10 used to be funding or design or something like that. But we realized that so many folks had lots of remaining questions at the end of the class, and we wanted to make room to be able to answer kind of the things that you're still curious about, which is why this year we're piloting this kind of closeout session for the first time, and are really excited about your engagement with this. So before today, we had sent out an email asking you all after the last session to provide some questions that you might have so that we could prepare to answer them today. And we got a lot of great questions from you all and from the facilitators as well. And our team did a really fabulous job trying to consolidate those into or group similar questions together. So that we can kind of knock them out together in batches. And so what we'll do for most of today is kind of go through one at a time, kind of the big common questions that were asked. Different facilitators will hop in and answer those questions. Ooh, I should probably switch to the agenda slide. Different facilitators will hop in and answer those questions. And we'll leave a little bit of time after each one to have additional comments from the group. We encourage very ample use of the chat to continue the discussion and ask additional questions, just because we'll be a little bit short on time trying to run through all of the questions. And then right at the end, there's a little bit of time for announcements, reminders, gratitudes, and a reminder for you all to take the post-course survey and tell us ways in which we can improve this for future years. Ready to get started, everyone? All right. Sarah, I believe you're taking the first one.
Okay, so I have the pleasure of getting to tackle the first question, which was a question that was actually submitted by more than one person. And it was the question of, what do implementation research teams actually look like in practice? And specifically, how are teams structured for efficacy and effectiveness research that applies implementation science? And for different stages of the IS research subway line, what might be some examples of project teams? So we actually have 12 amazing questions that were submitted by you all. We're going to try to keep it to about 4 minutes a question. So I'm going to share a little bit of reflection, open it up to any of you all that are here today to chime in and to provide additional examples. And if we're running great on time, we'll continue to seek input. But if we're getting tight on time, you'll hear us try to move on to the next question. All right, so my response to this amazing question is that it really depends on where you are on the subway line. As an implementation scientist, I would argue if you're early in the subway line, even if you're doing true treatment development efficacy or really early effectiveness, I would argue that it is always helpful to have an IS investigator on your team. You might not need them at very high effort. You might just need a little smattering of an IS person. I'm talking like 5%, maybe less, but that really can help you to think about issues such as designing what you are developing for later dissemination. It can also help you to prepare for implementation and think about downstream scalability. So I would argue you should always have an IS person on your team. I've had the joy of being that person on early efficacy and effectiveness studies. And usually that's like, all clinical researchers and maybe one IS person at a low effort. As you start to move down the subway and you're starting to think about hybrid effectiveness implementation trials, if you're doing just a type 1, often you only see one implementation scientist on that team. The level of effort might increase a little bit. You're probably thinking about 5 to 10%. And then as you continue to move to a type 2, type 3, you might actually have multiple implementation scientists on the team that have complementary types of expertise. Some people might bring expertise in things like research design and contextual determinants, in other issues such as implementation strategies. And then if you go all the way to a true type 3 or an implementation trial, many members of your team might be implementation scientists. And I would argue you also probably need some staff that are focused specifically on implementation science. I'm thrilled to say that this is actually something the Center for Dissemination and Implementation Science has been giving thought to, and we actually have an effort planning grid. So if you request a consult with us and you're not sure how to staff your study, we actually have examples. Like if your study looks like this and you're doing effectiveness, you might be thinking about an implementation scientist at a low effort. If your study looks like this, and you have an aim that is effectiveness and another aim that's equally important and is implementation, you might be thinking 1 or 2 implementation scientists, and we have some effort guidelines to help you to build your team. So please feel free to request a consult service with us. That is something that we have noticed varies a lot across studies, and we notice a lot of times the IS support is not amply staffed up, and so it is guidance that we try to incorporate into our consult service. Other examples are things that people would like to share to chime in on this one. All right, we can move to question 2, but again, feel free to use the chat. Feel free to unmute yourself and chime in if you have follow-up questions or anything you'd like to share. All right, and Dennis Lee's going to take this one.
Yeah, so another question that came from multiple people that we kind of combined together is that for individuals with no IS specific experience, how would we recommend getting into or starting to engage with implementation research? This is a wonderful question. And the way that I like to think about this is that, the things that you've been learning in this course about implementation science, it really is just a way to put systematic frameworks and methods and ways of thinking around everyday things that your implementers are already familiar with. So anytime you have an implementation partner and they're trying to implement something, they probably already know or want to know what is going well and what is not going well. So that's the implementation gap. How to measure, how things are going well. Those are the implementation outcomes. They probably want to know, why things aren't going well, or what are the barriers to implementation, and what can they do to improve? So in other words, what strategies can they use? So all of this stuff is things that are going through the implementation partners' heads already. Implementation science just helps put a framework around that. So to get started with implementation research, my recommendation is to engage with implementation partners early on and first get a sense of what they want to know and what they already know. And from there, you can pick the right theories, models, and frameworks and put things together, like using the implementation research logic model, so that you can figure out, what are the specific research questions that still need addressing and to prioritize. Now, some of our other great facilitators also chimed in on this question. They said to engage passively in joining, you can engage passively in implementation research by joining Implementation Center listservs for free or lectures. For example, San Diego has the DISC, the Center for Dissemination in California. And then you can follow implementation scientists on Twitter. And also, I'm reading off of the list here, suggest visiting the CIRC list of training opportunities. CIRC is the Society for Implementation Research Collaboration. And CDIS also has a training repository and a number of internal and external training opportunities. So please visit our CDIS website, and also you can also request consultations with us to ask about these questions. Any other follow-up questions from the group or thoughts? And I apologize, it's a little hard for me. I'm the one sharing the slides, so it's a little hard for me to see the chat.
I think, Dennis, the only thing I would say is don't be afraid to dabble, like if you have a project that you're just getting off the ground, it's a great opportunity to throw in a couple of implementation science measures. Make sure that you're thoughtful about which measures you use or which, constructs you're trying to capture, but don't let the enormity of implementation science intimidate you from engaging in it. And also don't feel that because there's so many different aspects to implementation science, you have to do them all in every study. You can take one, do another, just do whatever works for your study and addresses the questions you want to ask.
Thanks, Sarah. All right, let's move on to question number 3, and I believe this one is Kira's.
Yes, thank you, Dennis. So question number 3 said, what are effective approaches for authentically initiating community partnerships without reinforcing the hierarchical top-down power of academia, ultimately taking from organizations? This is such an important question to consider in your work, and I have somewhat of a two-part answer. So the first thing that I want to highlight is just the importance of beginning with an open discussion about interests and priorities. That I think coming in with a research agenda, sharing your research agenda is already kind of, that's where you get that top-down power dynamic, is when you kind of come in with what your ideas and your priorities are. So the most important thing I would consider is coming in to ask questions, listen first, find out what's important to those organizations and to those communities. What are the things that they find are the most pressing things to look into? And then from there, try to find common ground with them. What are some of the shared values, perhaps, that you both have? Where can your skill sets really map onto the things that are important to those communities? And I think that if you start from there and remembering that you're meeting person to person, not researcher to community member, I think you're going to be off to an excellent start. The second thing that I want to mention that is critically important is also making sure that in your research applications or any of the grants that you'll put together or project designs, that you are considering how you are going to compensate community organizations and community partners for their time. Certainly across many of the projects I've worked on, we see the most success when people are adequately paid and compensated for the work that they're doing, which should be of no surprise because we all want to be fairly compensated for the work that we do. So for example, if there's someone at a community organization who is going to use a % of their time to assist with the research project, find a way to build into the grant where you're going to compensate that % of their time for that person. Not only is it fair, it also signals that you are valuing the expertise that these folks are bringing to the project, along with whatever it is that you're bringing. So there are certainly a lot of wonderful resources towards community engagement and recommendations for building partnerships that you can find on the Center for Community Health's website at Feinberg. So I'm going to drop that in the chat. I also want to flag that they post their opportunities for seed grants, small pockets of funding that you can apply for to get these kind of partnerships off the ground that will help you to fund things like compensating community partners fairly. So I'm going to drop that in the chat, and now I'll just open it up to see if anyone wants to add anything or if anyone has any follow-up questions. Anything?
Especially if you were the people who asked the questions, please do feel free to unmute and let us know if you have any follow-up questions.
Absolutely. Nope. All right. Okay. We can move on then to question 4.
Okay, I have the pleasure of tackling question 4, which is, I think, a meaty question. It is, have you ever faced resistance from a community partner around some aspect of program implementation? How do you balance the need for scientific rigor and the autonomy of your community partners in large trials? I love this question. And the way I would answer this is that we try to structure our implementation trials so that implementation is an outcome and not an expectation. And I think that is critically important. We are basically seeing, can we help our partners to implement something in a way that is useful for them? We do not expect implementation to occur uniformly. In fact, the variability in implementation is actually often one of the key things we're interested in understanding what is driving that. And so I think for us, it's a frame of mind that we expect immense variability in the acceptance and resistance towards elements of the program implementation. And I think if you expect that up front and you can frame to your community partners that, we are seeing if we can help you to implement this in a way that is helpful to you, and there's no expectations that that everything will fit, that kind of puts it in a different frame. And I think that that's really essential. And that's certainly something that drives our team's work. I can't tell you the number of times that we've had like an implementation strategy or something that we are doing in our large scale trials that folks will say like this element isn't helpful, or not even helpful. It's that they just can't do it. We often have community partners that, if we have monthly meetings, not everyone will show up, or some people will show up, or different things will happen. And that's part of the study, is really seeing like what drives that variability, what drives the success for the people that do engage more than others. And I'd love to open that up for other comments, because I do think this is a meaty topic. Oh, and I guess I would say for me, I just want to specifically address the second question. Autonomy of the partners is the number one. It's because if you force a partner to do anything, I actually think you're jeopardizing the science if you do that, because we want to see, can we help our community partners to implement something in a way that's useful? And if you're pressuring them, or you're asking them to do something that's not comfortable or that doesn't align with their usual operations, it's not going to translate well to other settings. So I really strongly believe that autonomy should come first. And then the question is, can we work in a way that's useful to them? Yeah, Sarah, that's another meaty topic that goes a lot with our study design week of different types of models and ways to offer things, such as the rollout strategy that Hendrix shared.
Sarah, can you say a little bit more about how you've handled that? Because it does seem like a big challenge, especially from community partners who have geared up and are ready to receive the intervention, and then they learn that perhaps they're randomized to a much later start date, or are disappointed by the timeline. How do you work with that?
Is that a question for Sarah, me, or Sarah H? Who put the comment in the chat? All right,
I guess both of you. Yeah.
Okay, sure. So for me, that usually comes up before we design the study. And so that's usually often something that's in the grant itself as a rationale for the method that we're using. So as an example, I have a stepped wedge trial, or what Hendrix was calling a rollout design. And we were using that design because we felt partners were not willing to be randomized to no implementation, or randomized to something like, we were doing this in partnership with departments of health. It was really important to departments of health that everyone got the same intervention. I will say, I 100% have a study right now where people were not willing to wait. And that is something that changed from the time we wrote the grant till now. Basically, we wrote the grant 2 years ago, as one does in NIH world. We got the funding about 2 years later. And in that 2 years, the intervention we were helping to implement kind of like caught fire and caught public attention and got a lot of national press. And so agencies were like, I do not want to wait for 3 years to be randomized to get this. So when we were trying to recruit community partners, we realized we have to do this really on a consolidated timeline. So we took what was a like 55-month stepped wedge trial, and we're doing it in under 30 months, because folks were willing to wait a little, but they weren't willing to wait years. And I think you just have to be flexible. You can't, if the partner says, we're not willing to wait, my question is, well, how long? How long would you be comfortable waiting if we can promise you that you'll get it? Folks were like, maybe 2 years. So it was like, okay. The other thing we've been playing with in our team is giving everyone something at the beginning. So like if you use a rollout design, Hendrix described a rollout design where like everyone gets the exact same thing, but at different time points. There are variants of a rollout design. So one that we've been playing with is like giving everyone a training in year one. So everyone feels like they have some support and some scaffolding, and then layering in additional implementation strategies over time. This is something my team is like literally living right now. We have meetings like weekly where we talk about our study design modifications. So this absolutely does happen. And I think, it's all about being responsive to the partners.
I think for time, we should probably move on to the next question. But feel free to continue discussion in the chat, or let's come back to it when we have time at the end. Question number 5 is, Should equity be an implementation outcome or integrated into all outcomes? And I would say that given what we know about which populations and communities are always the most hardest hit, it's usually the same ones or very similar ones, regardless of health condition. I think equity should certainly become more standard and at least integrated across all implementation outcomes. Now, common outcome models like REAIM, for example, do a pretty decent job specifying this. When using REAIM and they ask about adoption, it's not just who is adopting, but it's also who is not adopting and why aren't the people who are not adopting it. So if you want to really fully specify and use a model like REAIM, there's a lot of guidance and resources out there to talk about how at each step, who are you reaching, who are you not reaching, and why aren't you reaching the people you're not reaching? That kind of gets at putting equity at each piece along the kind of the REAIM continuum. Now, representativeness and kind of external validity has always been really at the heart of D&I science, but a critique of where the field is currently is that IS is doing a decent job measuring inequities or equity, but doesn't necessarily integrate it sufficiently into all of the frameworks like determinants and strategies. So it gets integrated pretty well in the outcome side, as I mentioned, just with REAIM, but not so much the other determinant and strategy frameworks. So there's this is a big priority in the field. We don't have a ton of answers right now, but definitely folks are interested in this and trying to focus on this more. Any other thoughts from the other facilitators or any follow-up questions from the folks in the group? Thanks for dropping that in, Sarah.
Okay, questions 6, I think we're going to move along, is please discuss the tension you've experienced between number 1, using IS research to make a thing work within a potentially broken system, and 2, using IS research to sustainably improve that system for the future. This is another super meaty question, and I love that this question, I think, highlights this tension that many of our implementation studies tend to focus on kind of individual level determinants. So we look at patient level predictors, provider level predictors, but we often don't focus as intentionally on systemic and structural issues. I have personally experienced this tension that's asked about in this question in one of the streams of research that our team conducts, which is a program of research working with community-based opioid treatment programs. We've worked with 28 opioid treatment programs to date. And a key theme that we have found is that even when the individuals are enthusiastic and engaged, often there are systemic issues that lead to high rates of staff turnover, burnout, disengagement, and disenfranchisement with their positions. And it consistently shows just how important it is that the system itself is healthy when you're trying to implement something. Our experience jives really well with one of my all-time favorite implementation science articles, which is the Maslow's Hierarchy of Need article by Stewart and Bates and David, I'm forgetting his last name, but there's 3 authors. And basically that article talks about how implementing something effective is like a higher level need for a community organization, but they can't address that need until their basic needs are being met, such as keeping people employed, keeping the lights on, basically functioning. And I think we have certainly worked with programs that just what they really need is money. And without having sufficient funding, they can't really implement something. And I will say how I've dealt with that tension is that the more I work on that program of research, the more I've shifted to working with departments of health, because then I feel like I'm working with people that control the purse strings and control the actual funding and infrastructure. And that, for me, has helped me to feel a sense of now I'm helping on a systemic level by making sure that these programs are sufficiently funded before they actually are trying to implement. If others would like to chime in, I do think this is a big tension in the field.
I guess I would just add that if you are interested in making implementation research a big portion of your own work. I think these are two prongs of your kind of research program that can happen simultaneously, except the first one being stuff that you can do a little bit more immediately. So how do you optimize the current systems of care delivery to help your patient population or your client population and implement the things that you're interested in? Meanwhile, kind of the longer, like long-term research goal could be to how do you change the whole system? How do you, if you want to burn it down and recreate a new one, that often involves large, as Sarah mentioned, large economic decisions, large policy level decisions. So just in general, take a much longer time and probably can't happen with only research dollars. You'll probably want to tap into foundations and advocacy groups to help with that.
I would just add to what Dennis and Sarah have said is that when I was reading this while Sarah was talking, is I substituted the word broken or potentially broken for under-resourced. And I think that has really important implications as well, because I first started learning about implementation science within the context of infusing mental health promotion in non-healthcare settings, where they don't necessarily have the infrastructure or the time or the funding to be delivering these kinds of things. But they also recognize the incredible value that those interventions could bring to the families that they're serving or the communities they're serving. So there's still a lot of these organizations that don't necessarily have capacity to do a full-blown implementation project. They still want these things. And so I think it can be a really tricky balance to try and give them the things that they want while still making sure that the things that you're adding on to what they're already doing aren't going to overburden them or overextend their capacity.
Is my mic working? Okay, great. I had like my whole computer screen shut down. I think we should go on to the next question for time. And we should probably try to keep it to about 3 minutes a question moving forward. All right, and this one is our CEDAS postdoc. Sabine is going to tackle this one.
Great, thank you, Sarah. So the question, which is a really good one, is please provide a summary overview of standardized. Oh,
and Emma, we should be on 7.
Oh, yeah. Sorry.
Oh, it's Dennis, sorry.
Summary overview of standardized tools or widely accepted tools to assess various aspects of the implementation process, like barriers, facilitators, acceptability, appropriateness, feasibility, etc. What I wanted to do was to drop some resources in the chat in an attempt to tackle this great but very big question. It's going to come in as a whole bulleted list. But I would say that because implementation science is a relatively new field, that there is still a lot of progress to be made in terms of consensus on standardized measures and tools. But in terms of best practices, broadly, recommendations for tools may really depend on what you are trying to measure or assess for your specific project or your specific initiative. So for example, if you're looking to do a needs assessment and to identify implementation barriers and facilitators, the CIFR website has a really great qualitative interview guide. But if you're interested in trying to assess more quantitatively barriers and facilitators, there is a really great repository of measures published by ISRG, which we've talked about, the Society of Implementation Research Collaboration, that lists some of these out that you can use in your projects. I did want to mention that the repository requires you to be a ISRG member, which is a paid membership. But the good news is that CEDAS has a paid membership to ISRG. So if you email us, you can get access to the tools and we can help you navigate that website. If you're looking to measure more implementation strategies or outcomes, Proctor and colleagues have 2 really great papers and recommendations for defining strategies and outcomes, which can serve as helpful guides. And I know that Dennis and the team at ISKI have done a really great work in this area, so I'm happy to let him talk much more about that.
Sure, I'll just really briefly, I'll say that in the field, I think standardization and harmonization are still much needed tasks. And one of the things that ISRG, the HIV Coordination Center for Implementation Research, is doing is we developed an outcomes crosswalk to try to get all of at least the HIV research, HIV implementation research, to be using the same outcomes. And I know several initiatives in other health domains like cancer are doing the same. And so that might be a good place to start with in terms of standardized tools. But there's a lot of work to be done in this area. Shall we move on?
I think Dr. Allison Carroll is going to take away number 8.
Yes, so I'm answering the question, what do you suggest including in the implementation science training plan for an F32 or early career award, and asking if there are any resources for reviewing previously successful examples of these grants. And so I'm just going to share what I have put into my K23 application, and the way that I went about it was I just tried to make each of my training aims very similar in the level of training that I was trying to get. So I chose like a very intensive, high level, like week-long training. And so for that, there's the Implementation Research Institute is one of those. But there are a couple of others that have popped up more recently, where you go for a week and then maybe have another year or two of follow up of mentorship and peer mentorship and collaboration, which is really great. And then kind of my next level was thinking about conferences that you can attend. And I proposed that I would go to one new conference, so specifically like the D&I conference hosted by Academy Health, but then also a conference that I usually attend that happens to have a special interest group focused on implementation science, or that have had trainings for implementation science, so that you can still be doing that within the community that you are more familiar with. And then I always tried to figure out some sort of training that I could do that would be related, and this ended up being something that was requested of me because I don't have a background in hypertension, and my project was focused on a behavioral intervention for folks with hypertension. And so I proposed doing some observership so that I could actually see what the workflow looked like in measuring hypertension in different settings. And so some applied kind of hands-on. And then of course, anything that you do in your research project is also training for implementation science, and your meetings with your mentorship team. And I also just want to point out, so where resources do exist for this are within CDIS. It's wonderful. You can go there for anything basically. So they not only have examples of K and F awards that have been funded, but they also have a resource document to help you to select some of these training activities that make sense for you and your project. And you can always request a consult to be connected with those resources.
Right, and Amy just put a wonderful resource in the chat too, a paper in press that describes support writing in F31. We have a really nice Word document in CDIS that basically lists implementation science training opportunities specifically designed for Ks and Fs. So please do feel free to reach out to us. And we are partnering with NewCats to build out our repository of funded grants as well. And we do have funded Ks and Fs, and then Rs and whatever other mechanisms you might want as well. But please feel free to reach out to us.
All right, I think we'll move on to the next one. So I'm actually going to be tackling the next 2 questions because they're very similar to each other, and they build off of some of the answers that Sarah was saying before. So the first of the 2 is, as a clinician interested in implementing something new in my clinic or center, how should I decide whether it is worth going through the trouble of leveraging implementation science principles for intervention rollout and or conducting implementation science research? And I'll echo what Sarah said earlier. It doesn't matter how early it is in the translational spectrum you are, it is always beneficial, we think, we might be a little bit biased, to have some form of implementation research or implementation research question embedded in there, just because it will ultimately, the principles, particularly implementation process, may not only be helpful in in studying the implementation, but just in general helping you or your partners kind of guide implementation. A successful implementation. I think this is a really great example of where program evaluation, quality improvement, and implementation science all overlap. So if you're doing any type of evaluation and or quality improvement along with this new thing that you're trying to put into place, then embedding 1 or 2 IR questions, implementation questions, should be pretty simple to answer, or should be pretty easy to do to answer some of those earlier stage questions. It doesn't always have to be, as we've talked about, implementation research doesn't always have to be a massive or complex trial. It can be one miniature question at a time, trying to understand what the context barriers are, or what strategies would be best to use here. I think if there are some big research questions that to be answered that only a large trial or a large study could do, that's when you have to ask yourself whether or not you yourself want to lead it or participate in such a large initiative. But as we've also mentioned, there's a lot that can be done in implementation research that can happen without randomization. So a lot of, and there's more work in the field being done on this, these pragmatic designs that are less burdensome on the institutions. And I'll just roll. Oh, go ahead. Yeah.
I just wanted to add one thing too, and that's
Yes.
that also that all of the information that this group has learned about implementation science and implementation methodology, even if you choose not to do implementation research, you can do your QI projects and your implementation projects better because of all the information you know, because you're going to use that information on sustainability and acceptability and understanding readiness. So it doesn't always have to be a research project. But we really like it when it's research.
Thanks, Miriam. Sarah, did you have something you wanted to chime in on?
I was just going to say that Miriam's point was an outstanding segue to question 10.
Question 10 is, if a QI initiative is planned, what are some simple strategies to layer in an implementation science evaluation? And so a couple examples that we've probably given you throughout the course, like some pragmatic surveys for pre-post levels of acceptability, feasibility, readiness. In my own work, conducting a learning collaborative, we do what is called temperature checks right after kind of each in-person meeting, and it's like a series of 10 questions of like, how are you feeling? And how acceptable do you still think this intervention is? How implementable is this? So really short, pragmatic ways to get partner input on implementation over time. We also, in my work, kind of put in periodic interviews, like really infrequently, 1 or 2 a year, of just conversations with the implementers about how are things going? What barriers have you encountered so far? Has anything been helpful? And that gets at your barriers and facilitators pretty easily. And then finally, you can kind of use or identify some administrative implementation outcomes for pre-post measures. Some things that outcomes that don't require a lot of burden to collect on the participants. So anything that comes from surveillance data, if that is applicable to you, or aggregate patient chart data that you could use as implementation outcomes. I'll also add, you can track kind of implementation process doing something called, like, I call thick light, or stages of implementation completion light, where we're just kind of following where are they in the process. Have they had a meeting about this? Have they talked to a funder about this? Lots of pragmatic ways to incorporate it into the Q&A or QI. Any other thoughts from folks? All right, we have a couple left, and then we want to open up some time. So I'm going to move us forward. Question 11, I think this is Sarah's again.
All right, this one's me. So this question is there or should there be a composite implementation outcomes measure so we have a single primary outcome? I think in brief, the answer is no. And the should there be, maybe. And so we've actually been struggling with this on one of our center grants funded by the National Institute on Drug Abuse, where we're supposed to harmonize across 12 grantees. And the funder asked us, like, is there a single measure that everybody should measure? And what we decided was that there was 2 that we at least wanted them to measure. And we decided on reach and adoption because we felt that it was really critical to know at the end of the day, how many people are benefiting from this thing that you're implementing and how many people are actually willing to pick it up and deliver it. And we felt like those were the 2 critical temperature checks for any implementation effort. I know, as the wise Dennis Lee said when we were preparing for this group, really at the end of the day, we want to understand impact, which can be thought about as kind of the intersection of reach and effectiveness. But I think he wisely noted that we often don't have a good sense of that in our trial because it's really hard to like wrap our heads around that and conceptualize it in most studies. And that when we don't see impact, we often don't exactly know what went wrong because there's like an impossible number of possible moderators, that we can't usually look at. So again, I'll just come back to the answer that no, there isn't a single composite. My team has decided to focus on reach and adoption, but that wasn't really scientifically driven. It was just a team of implementation scientists feeling like those were critical outcomes that we needed to look at. All right, I think we have one more question. So any comments about this, about outcomes measures before we go on? All right, and then our last question is going to be Sarah Helsap.
All right, our last question was, please provide specific recommendations for conducting implementation science research in unstructured systems for those with limited oversight, like working with individual partners rather than a larger healthcare system. Some of the strategies and the research designs that we've learned about in this course seem like they might be difficult to apply in clinical settings where clinicians work independently, like they work for themselves, and don't receive significant feedback or supervision. So I touched on this a little bit earlier when I was talking about my prior experiences working in systems that weren't built to deliver healthcare services, or working in like partnering with a specific, when I say organization, I mean it's an N of one. It's one organization, one site, 4 or 5 people. It's much more important to really think about their capacity and finding ways to balance the rigor and the science with their ability to take on additional work, while still finding a way to help them implement whatever it is you're trying to implement. So when I think about these, I think that you should, if you're partnering with an organization like this, that either doesn't have built-in oversight or is a very small scale organization, you want to still be asking yourselves all the same questions that you would be asking at a larger organization, but you might need to look for solutions that are more small scale. So for example, in some clinical studies, we might ask for supervisors to check in with clinicians, asking them whether or not they're delivering the strategy that we're implementing, or they're delivering the intervention that we're implementing. But if you're in an organization where there isn't supervision, look for other opportunities where you can have somebody who is the leader of that organization check in with people to get that information. So it might be something like capitalizing on an existing staff meeting. That's what I did in my dissertation, which I joined at an after-school program in a faith-based organization. So I just started attending their staff meetings, and I used that to give 5-minute quick clinical supervision on the activity that we were doing. Or alternatively, you might need to build that infrastructure yourself in order to conduct the research at that level and ask those questions. I know this is our last question, so before I finish out, does anyone else have any other comments or thoughts about this particular question? All right. All right, I think that this, correct me if I'm wrong, I believe this was our last question. So now I'd like to open it up to anyone else who is here today that might want to ask a question. You're welcome to raise your hand or unmute. You can also write your question in the chat and we will answer it live.
It's okay if we don't have any, but if you do, don't be shy.
I know it's a little, it might be a little intimidating to ask in front of 45 or so people, but
I have a question.
Great.
So it's about getting a consultation or consultations with CDIS. I have 2 projects right now that are sort of in the ones pretty far into implementation, and we're trying to figure out where to go next with what isn't working and with the time that we have left on the grant. And another one is at this sort of point between the pre-implementation work where we've designed what we're going to do and finding out whether we're going to get the funding to do the thing. I want to make the best use of that pre-implementation data, preferably before we actually do the whole implementation and get to the end of the study and then want to publish the outcomes. Are these like appropriate conversations to have with CDIS? Any advice for me real quickly right now?
Absolutely. And in fact, as we go forward, I think we have a visual about our consult service to try to emphasize the breadth of things that can be requested. But yes, we have specifically revamped our consult form. It used to be called a grant consultation service, and it is specifically not called that anymore. It is just called a dissemination and implementation science research consult. And we give some examples of the types of things that can be requested. So it can be grant design, review, or support. When you fill out the form, I think we specifically ask if this is pre-award or post-award, but we do both. And we do a lot of general requests too. So people will write, because they want to write a manuscript and they just want to be thinking about the right implementation science language, or they're thinking about training their teams or other things. But you can request pretty much anything related to D&I through here. This is meant to be one-stop shopping through NewCats, where there's like a single click. Every once in a while, we'll get a request for like a project coordinator, and we're like, oh, that's like our friends at the Center for Clinical Research, you know, or something might be more of a community engagement request, but we can help facilitate that warm handoff for you. So please feel free to request. I think both of the projects you mentioned would sound right in the pocket and like an extremely productive point of conversation.
Great. Thank you. You'll be hearing from me.
And just to highlight in the chat, Jamie asked a question about whether or not we provide consultations for student projects, and the answer is yes. That and many other types of projects.
I will say that over the last couple months, we've gotten some requests from outside of Northwestern, which I think is a great sign of awareness that we're doing implementation science here, but I will say that's our lower priority. So we basically prioritize faculty and students within the Northwestern system, and if time permits, we will do outside of Northwestern, but folks that are at Northwestern get the first priority.
And Sarah, does that include Northwestern partner organizations like Northwestern Medicine, Lurie Children's Hospital?
Of course, yes.
Okay.
So all our clinical affiliates as well. And of course, if you are like a mentee of someone at Northwestern, but you are outside of Northwestern, I would just ask that your mentee fill out the form so that it appears as if it's initiated within Northwestern. I know we have some people in this course from outside of Northwestern, and that is totally an appropriate use of the consult service, but we do ask that it be initiated by someone within Northwestern, just so you're triaged appropriately.
Other burning questions? You have a whole panel of experts ready and willing to answer, solve all your problems.
Great. You are welcome to unmute or put questions in the chat as we keep going. I think we can proceed to some of the next slides, which are just some closing requests and thank yous for you all. So before we end with a request, we just want to again publicly thank all of the small group discussion leaders and guest speakers. So we have folks that every week we're meeting with you all listed on this slide, as well as some of the speakers that came for one-off lectures, and we really value every single person that came and lent their expertise to us. And I'm not sure if there's animation for a little star next to Emma, but I want to, yes, so we have Sarah and Miranda were two of the behind the scenes folks that were doing a lot of the heavy lifting, sending you reminders for each week and preparing our survey. And then Emma every week was making the magic happen of assigning you to the Zoom rooms, letting folks in from the waiting room, and just keeping everything going so seamlessly. And so we're so grateful to that powerful trio for their work, making everything so seamless. And then we want to thank you all for coming and encourage you to keep connecting with us. So if you're not a member of the Center for Dissemination and Implementation Science already, please join us. There's a link here. If you join us, you'll get our monthly newsletter, which does a roundup of D&I resources, training opportunities, kudos to folks in our community. We also, in the academic year, have a monthly forum. We are on break for the summer, but that will resume in September. I'm hoping with an in-person monthly forum so that we can introduce you to some powerhouse new faculty and postdocs. And we can go on to the next slide. Please, before you leave, please heed these words to please take your post-course survey. We really do use the feedback every year. As Dennis mentioned, the structure of this year was directly influenced by feedback last year. We added the QI session and we added the post-course wrap-up session. We would greatly appreciate your feedback. Emma just put a link in the chat to the survey, and you'll also be getting an email. We would be so grateful to you if you were to do it. And then I think we have a final visual on the next slide, which is just to emphasize that we appreciate all of you. This was a wonderful group of folks. We recognize 10 courses is a long time to hang out with us, but we really appreciate the engagement and attendance. And we appreciate all of you who volunteered to be peer group discussion leaders. This really took a lot of your time and effort at a busy year. And we just really appreciate you for making this experience really positive. So thank you all so much for joining us and for the wonderful experience.
And yes, the survey is very short, as Sarah Helsa just put in the chat. It's about 5 minutes. We kept it pragmatic for you all. And we really would appreciate and do appreciate the feedback so that we can continue making this better and better for courses to come. And feel free to take it again, recommend it to your friends and colleagues. We love to see all the faces and interest.
Dennis, I think we actually had some people who participated in this year's course that had previously participated in the course. So you're always welcome to come back.
Always more stuff to learn.
Yeah, and if you want to take it again and would like to lecture at all, or if you felt like you wanted to, yeah, please let us know. Thank you all for the comments in the chat. All right, thanks all.